now, like anywhere else, they are promoted. So,
yes, sir.
The lots of
sir, namaskar.
Sahai sir, namaskar sir. Good evening, sir. Good evening, sir. Namaskar sir.
Namaskar, sir. Sahai, sir. Nice seeing you, sir.
Kanakwel, we can't hear you. I think you are muted.
Good evening, sir. Rahul, sir, good evening. Thank you for joining. And I think it is 8 o'clock. Let us start the session. We have very eminent faculty for the day. Professor Pankaj Modi, sir, Professor Rahul Khanna, sir. And we expect Professor Gaurav Agarwala by about 8:45 or so. Apparently, he's in the institute meeting, it seems. So he requested the thyroid case be kept in there as a second case. So that is the information. And I welcome Srinivasan sir, Rajgopal sir, Rajiv Sahai sir, and other senior faculty here. We have two important cases for the day. Parotid tumor, kindly contributed by Professor Lingam Sridhar. And this girl is from, Naeem is from Deccan Institute of Medical Sciences, Hyderabad. And we have the Dr. Kiruba Evangeline from Professor Jailan sir's unit at Government Kanyakumari Medical College, Kanyakumari. So let us start this session. I think all the examiners have been with us sometime before. So let us follow the same thing. The candidate will be allowed to present till the history without stopping anywhere. And then you can revisit the slides once again, slide by slide, to rectify or comment or ask questions. Same way, the clinical finding is allowed to present in a non-stop fashion. End of it, you can revisit the slides and ask questions. So the invited faculty take the priority to ask questions. Of course, seniors here always are with us for the last, say, today. In fact, we have 171st class, and we have more than 340 cases have been discussed over the last 3 years. So thank you everyone for allowing me to continue this journey and being part of it every week after week. And any meeting we go, we are happy to listen someone telling, sir, we were benefited out of this. So in fact, I should put on record, we have now 12,000 plus subscribed viewers. Earlier we had around 10,000, and some time back we crossed 4 lakh viewership. So I think we are going good. And there have been some requests telling we should ask for short cases, we should have others. At this point, I'm going this as a model, but in future, maybe if all the faculty want to tell us that we should have some form of short case discussion, we should consider. Maybe we can have 3 cases like that if it is a short case, so that it can get over. So please give your suggestions so that I will take it further. So with that words, I invite Dr. Naeem. Introduce herself, her unit chief, her head of the department, and then start her presentation. Good luck to you, Dr. Naeem. Faculty, please take over.
Thank you so much, sir.
Can I please share your slides?
Yes, sir.
Yes, you are good to go. All the best.
Thank you so much, sir. Yes, sir. A very good evening, everyone. Sir, am I audible?
You're perfectly fine, ma. Good to go.
Thank you so much, sir. A very good evening to all the eminent faculty. Thank you so much for giving me this opportunity. I am Dr. Naeem Nissa, final year surgery resident from Deccan College of Medical Sciences, Hyderabad. My guides are Dr. Nusrat Faris, Head of Department of General Surgery, Avesi Hospital, and Dr. G. Raghavendra Prasad, Pediatric Surgeon and Professor, Department of General Surgery, Asra Hospital. I will like to start with my presentation. Starting with the chief complaints, a 52-year-old lady presented with a painless swelling in front of the right ear lobule for 2 years. Coming to the history of presenting illness, the patient was free from present complaints 2 years ago when she developed a painless swelling in front of the right ear lobule, insidious in onset, gradually increasing in size, increased twice in size to the present state. There was no history of rapid increase in size of the swelling, no history of pain in the swelling, no history of ear pain, no history of fluctuation of size of swelling while chewing, and no history of excess salivation or purulent discharge in the mouth. There was no history of dysphagia, no history of difficulty in opening of mouth, no history of any other swelling on the contralateral side of the face or the neck. There's no history suggestive of facial nerve involvement, like no history of deviation of angle of mouth, no history of facial asymmetry, no history in difficulty in chewing food, no history of drooling of saliva from the angles of the mouth, and no history in difficulty in closing eyelids. There's no history of loss of weight, no history of dryness of eyes or joint pain, no history of radiation exposure. My patient has nil known comorbidities. She is a non-smoker and there is no history of alcohol intake. Past history, there's no previous surgical or medical history in my patient. Her family history is non-contributory. At the end of my clinical history, my summary is a 52-year-old lady with no known comorbidities presenting with a single, painless, gradually progressive swelling in front of the right ear lobule for 2 years with no other associated symptoms and no history suggestive of facial nerve involvement.
Dr. Naim. Yeah,
Good
sir,
morning.
please.
Good evening, sir.
Good evening. Sir, please. Okay, yeah.
Please continue, Dr. Naim.
Shall I continue, sir?
No, Dr. Naim, we'd like to discuss on the history.
Sure, sir.
Right. So by your history, what do you think you're dealing with?
Sir, by the history of my patient, I'm most likely dealing with a benign swelling of longer duration, non-inflammatory in pathology, and most likely related to the parotid region, sir.
Very good. Okay, let's just go back to your first slide, please.
Okay.
Okay, so this is a swelling in the parotid region.
Yes.
What is the parotid region?
Sir, the anatomical landmarks of the parotid region are defined by two horizontal lines, the superior horizontal line passing through the zygomatic arch and inferior to the angle of mandible, and two vertical lines, the anterior vertical line passing from the midpoint of zygomatic arch and the posterior vertical line passing through the center of the mastoid, sir.
Okay. So suppose this was a lymph node. What is the drainage area of this lymph node then?
Pre-auricular lymph node would be a lymph node that would be found in this area, sir. And also we could find some post-auricular lymph nodes also in this.
I'm asking what is the drainage area of lymph nodes in this region? Which area would be draining into these lymph nodes?
Sir, the side of the face, the temple, cheek, and the area around the auricle would be draining into these lymph nodes, sir.
So it's like this.
Yes,
like
sir.
This.
One side of the entire face, one side of the.
Next slide, please. Okay, so 2 years. Why did you ask for history of ear pain?
Sir, we know that the facial nerve can be involved because of the where the swelling is anatomically located, but because the auriculotemporal branch of the mandibular nerve of trigeminal nerve is also has interneural connections with the facial nerve in this area, there could be a referred ear pain that the patient might experience. Apart from that, if this swelling were a malignant swelling, then because of infiltration to the TNJ or to the pterygoid muscles, there might be some sort of pain. and also because there is the ear also present in that area. If there's some local infection to the external auditory meatus, the patient would also complain of ear, sir. Ear pain, sir.
Pain in the swelling?
There is no pain in the swelling, sir.
Why did you, what was the cause of pain in the swelling then?
Sir, very large parotid swellings in that area would stretch the parotid capsule and cause pain. Apart from that, if it's not a parotid swelling,
No. Sorry. No.
if it's an inflammatory swelling in that area, then it would be causing pain. But because my history is of 2 years of duration, unlikely to be.
Suppose there was a stone. Is that swelling painful?
Yes, sir. If there is stone in that area, then it would be associated with pain. And stone in the parotid duct, you're asking, sir, or?
Yes, stone in the parotid duct.
Yes, sir. Then there would be pain during, the patient would give a typical history of pain during chewing, and also a significant increase in size of the parotid gland during chewing.
Naim, I would like to differ there. Why do you say pain during increase size during chewing? What is the relation?
Sir, because there is a stone blocking.
Forget about stone.
Okay,
Simply
sir.
you say, what is the relation of chewing with size of swelling?
Is it chewing actually? That's what he wants to ask. Is it chewing or is it
Chewing
something
or
else?
something else?
Anything that increases salivary stimulation.
So only
sir.
chewing will increase the salivation.
Taste, smell, sir. Smell or taste.
Not really smell. If you take anything, what do you ask in the, suppose you have a patient you suspect of has a parotid swelling because of a stone.
Yes.
What do you ask the patient to do?
In your examination, sir is asking.
I would.
You're sitting in an OPD, we have a
Yes,
patient. He says, sometimes I get a swelling here. So what
Yes.
do we tell him?
Any local restriction of movement?
No. Sir is asking, how will you make the salivation? I am giving you hint.
Right. Okay.
By
Correct.
giving the patient some sort of stimulant, like something to some lemon or.
Yeah. Ask them to suck on a lemon.
Suck on a lemon or vitamin
Second-
C, suck C, chewies, they are available. So that is more important rather than
Yes.
chewing itself.
To
And the second question is, if the pain during chewing, what will you suspect?
If there is a pain, I would suspect blockage of the parotid duct and.
No. I am asking you pain during
chewing. When you are moving your jaws.
Then involvement of the TMJ or pterygoid
Right.
muscles, sir.
Right. You asking or you telling?
Asking. So I'm telling. I'm telling. Sorry, sir.
Okay. Right. Okay. What about excessive salivation? Why do you ask for that?
If the patient has a residual, like if she's holding saliva in her mouth, apart from normal times, like if there is collection of saliva in the mouth, in the vestibule of the mouth, I would
What
ask
that
that
tell you?
history.
What
from the
information
patient.
do you get by that? What do you infer?
Sir, two things that could first suggest, like I said, stone pathology, or it could even suggest that facial nerve involvement is there because of weakness of the buccinator. The patient is able
You're carrying it too far,
okay, sir.
right?
Yes, sir.
Excessive salivation is not because of parotid. Why should the parotid, unless you're getting stimulation all the time, right?
Yes.
Decreased salivation, I would agree with it.
Yes, sir.
Excessive salivation has got nothing to do with here.
Yes, sir.
Purulent discharge, why?
Sir, if it's a case of parotid fistula, then the patient would give a history that there is some discharge that she's noticing in her mouth.
Purulent. Why purulent?
It could be serous also, sir. Actually, parotid
No, you've written
salivary
or purulent.
secretion.
Sorry, Dr. Naim, I know,
Yeah.
I'm sorry.
If the submandibular involvement, submandibular gland involvement is there, sir?
No, you said purulent discharge in the mouth. So is it from the parotid or is it from the submandibular gland? Or from either?
From either, sir. From either. If there.
She doesn't have any other swelling. You said that only just swelling
Yes,
front
sir.
of the parotid. So what do you think could be leading to purulent discharge from the parotids?
A parotid fistula, sir?
If there is a stone and there's infection, right?
Yes.
Okay. Next slide. History of dysphagia. Why did you ask for that?
Sir, if there is deep lobe involvement of the parotid gland, then if that swelling reaches a very considerable size, then the patient might give a history of some restriction during swallowing of food, because it pushes on the, it is present just in the lateral pharyngeal wall. It's present in the lateral pharyngeal wall.
Okay, we'll take it with a bit of salt, with a pinch of salt. Okay.
Yeah.
Look, all this thing about facial nerve, just say, right?
One
nerve
line.
involvement, rather
Yes, sir.
than a whole Dhobi list of all the symptoms, right?
Okay, sir.
Next slide, please. Dryness of eyes and joint pain. Why did you ask for that?
Sir, in autoimmune disease like Sjogren's syndrome, there might be involvement of the parotid glands. So just to rule out if there's any autoimmune history, because those are associated with connective tissue disorders like SLE, which has, and also keratoconjunctivitis sicca and xerostomia, to rule out any autoimmune pathology in this case.
Like-
what would really, right? So,
Like what pathology you will rule out in parotid?
Sjogren's syndrome, sir, of parotid.
Anything else?
Sir, Mikulicz syndrome is also a variant of Sjogren's syndrome.
Mikulicz
in which-
disease.
Mikulicz is not syndrome, it's a disease.
It's a disease.
Disease, sir.
Okay.
Similar to Sjogren's. Yes.
Second question I have got is, you have asked so elaborate history, as sir has said, you should simply say no facial weakness or abnormal, right?
Yes.
Have you asked any dental history when you are going for this dysphagia and this all? Have you asked any dental history?
No, sir, I have not
Isn't it more important than dryness of eye and joint pain? Can it be related to the swelling in the side of face? Do you understand my question?
Yes, sir, I understand your question.
So is it possible that patient can have a dental caries, abscess, or some tumor arising from there, which can mimic parotid?
Yes, sir, it can be
It's
possible.
always particularly, you should ask. Particularly, my advice is that don't go this much detailed history. It is not required, because we are here to present a case of parotid. So why did you ask history of radiation exposure?
Sir, a few parotid, rarely, but a few parotid gland swellings like adenoid carcinoma or mucoepidermoid, as well as Warthin's tumor, have a history of radiation exposure, or even this could be a lymphoma also, which could have.
Which books gives that details?
Exactly. I have never heard this. Huh? I'm sorry, I may not be right, but I have never heard this.
I also not
Radiation
read like that. Radiation exposure is called for the Warthin's tumor.
So lymphoma could have.
Right. Lymphoma is fine. Lymphoma is fine. But your take on Warthin's and adenoid cystic or adenoid carcinomas is not. They are not related to radiation. Okay.
Oh,
Right.
okay, sir.
Anyway, the parotid and radiation has very, very rare combination.
Yes.
I don't think it is required to say about radiation exposure here. I don't know from where did you get it. Even in thyroid now, people believe that is not it is a superfluous history to ask. Previous history of radiation exposure. So don't do that. On one side, you are thinking of benign disease. Which benign parotid tumor which caused by radiation exposure? I don't know. Anyway, let it go. Don't show that.
Your entire question is on secretion, pain, with the parotid stone like this you are going. You said Mikulicz is also an autoimmune disease?
It's a variant similar to Sjogren's.
Sjogren is autoimmune. Variant means it is also an autoimmune.
Yes.
What is
So
Mikulicz? What is Mikulicz?
Uh,
You have an
we
idea?
have
What is the difference between Mikulicz and Sjogren?
So histologically, I think they are similar. It has a parchment-like dryness of.
No, please
mouth.
understand. If it is histologically similar, we will not give two names to that.
Yes. There is a parchment-like dryness of the mouth and lacrimal gland involvement, which causes narrowing of palpable fissure.
Both the
sir.
condition, you will get the lacrimal gland. What antibodies will be there in Sjogren?
If it's associated with SLE, then I'm not sure. So
Okay, we go back and read because Sjogren, it is separately
Yes.
then what is then SSB low row
SSA,
antibody.
yes.
Miculis is reversible condition. Sjogren, once it is goes, it is not a reversible condition. So
Yeah.
apoptosis will be
Yes.
there. So all this you met or read. It is not a pure disease. Okay.
Exactly. And
Many-
I don't
many
think it is taking it too far. Yes, sir. That
Many
asking
points you are bringing unnecessarily here.
yes.
Sir, I have,
You are asking
three
unnecessary questions and creating problem for yourself.
And that also not
Dr.
in an
Naim.
order. You are talking about facial, talk facial nerve together. Then other things together. Because you should not bring, suddenly you are talking about loss of weight and suddenly bringing about the radiation exposure later part. So some way how you are going to go in an order or you are too much you are concentrated on excess salivation, which is, do you have any parameter to decide the excess salivation? How do you decide there is excess salivation or not?
If you, Dr. Naim, if you have a patient of CA tongue, how does he present to the OPD?
He can present with the ulceration
No.
on the tongue.
No, he has a handkerchief in his hand and he keeps spitting into it, doesn't he?
Yes.
So that is excessive salivation, right? Okay, about this Miculis and Sjogren's, look, you dug your grave because by mentioning Miculis is a portion of Sjogren's, we agree with it, but you got to be more convincing. If you write something in your history, you should be able to defend that whatever is being asked, right? Don't back down if people say that
Yes.
something. You should be able to defend it, okay?
Yeah.
Because you're going to be a surgeon very soon, right? Sir,
There is a
please.
question I was asking about dental part. Is there any relation if there is something wrong with the upper teeth line? Can it cause something to with the parotid?
So the parotid duct opening is present at the upper jaw, so upper second molar. So if there is a dental, it could.
It is opening opposite
Hmm.
the upper second molar. Okay, it's not at the second molar. It's just
Opposite.
opposite at the buccal mucosa. Okay.
Okay, I think in examination we'll come to that later. But the bottom line, as sirs have said, do not do this much elaborate history. It is not required. We are here to give bare facts. So stick to bare facts which are there. And don't think too much because as sir has said, Sjogren, Miculis, so that is not a part of at present discussion. Don't put it in your head. Okay, please, sir. Shall we
Yes.
allow her to continue examination, I think?
Senai sir has
I have one more small question. I don't know whether
Yeah.
you clarified that. You have written no history of fluctuation. I don't know whether it has been
that
clarified by
is we discussed, sir.
number
But
one.
that
Number
word should not be used.
Yes.
Hmm.
Number two, that you mentioned the pain in the ear is due to some, we are given some explanation with some branches mixing with the facial nerve somewhere, I think, correct? Did you mention like that? Hello? Hello?
Facial nerve branches.
Hello?
Facial nerve branch.
Yeah, but
Facial
I
nerve-
would like just ask you one question. Do you know the branches of mandibular nerve? What are the area it supplies? Mandibular nerve. You know, it has got a huge supply, anterior, posterior branches. It also supplies tympanic membrane, external auditory apparatus, auricle, so many things. In addition to the parotid gland. So the reason why they
Yes, sir.
often they come with itching, some kind of itching and all in the ear. So that is the
Yes.
more likely explanation because the wide areas by the mandibular nerve, both anterior. Okay. Yes. And trichomoma, one of the important area which also is eyelid. Don't forget eyelid. This is actually a tumor from the upper sheath of the follicle. This the discussion on the trichomoma. And one question to you: when this parotid region nodes are enlarged, what are one or two possibilities you would like to consider if it is malignancy, apart from the trichomoma? Somebody
In the
comes here,
clinical history, sir.
when somebody comes in this type of notes like this parotid, you said parotid gland enlargement, first thing you will consider. Second is could be nodes, that's what lymph nodal mass. If it's a lymph nodal mass
Yes.
malignancy, what one or two possibilities you
Battery
would like to consider?
90%. Connected to PASKGOP PII657C.
So, lymphoma, sir.
Yes. So you also like to consider lymphoma in addition to some.
PASKGOP
Don't forget
PII657C. Disconnected. Ready to connect.
melanomatous lesions, don't forget. Okay, sir.
Yes, sir.
Even in the history of us here, facial asymmetry, suddenly you are going to difficulty in chewing, but then again drooping of the saliva. So one is, both are, all the three are same nerve?
Sir, if in facial nerve palsy also, the patient might not able to chew properly. The food might get lodged in the vestibule of the mouth, sir. That's why I asked.
Chewing. So what do you mean by chewing? What is responsible for chewing?
The muscles of mastication, sir.
So they have any relationship with the facial nerve?
No, sir. They are supplied by mandibular nerve, sir.
So fluctuation of the parotid will happen in which condition?
In
Battery
90%.
90%.
Fluctuation of the size of the swelling, sir.
Yeah, fluctuation and this engorge.
So in silolithiasis, sir.
No. It is very common in hemangioma. When if
Yes.
it is hemangioma of the parotid, you will get that when you are clenching the tooth, it will be
Battery
become
90%. Connected to D.
okay. Go ahead. I think you can go for examination,
So shall I proceed, sir?
please.
Coming to the general examination, consent was given for examination, privacy was provided, and the patient was examined in a well-lit room in the presence of a nurse and one female attender. Patient is moderately built with a BMI of 21.46 kg per meter square, a Karnofsky performance score of 90, vitals are stable with a blood pressure of 120/80, pulse rate of 86, respiratory rate of 14 cycles per minute, and the temperature is normal. This is a clinical picture, sir, of the swelling. Coming to the local examination, patient was examined in a sitting position. My findings on inspection were, sir, am I audible? Shall I continue?
Go ahead.
Yes, please.
Yes, sir. And approximately 4 into 4 centimeter solitary spherical swelling located in front of the right ear lobule. The extent approximately was 0.5 centimeter from the tragus, 1 centimeter below the right zygomatic arch, 1 centimeter above the angle of the mandible, 2 centimeter in front of the mastoid. There was no change in the position of the right earlobe. Swelling appears smooth with no skin changes. It shows well-defined margins and there's no obliteration of the retromandibular groove. There's no facial asymmetry on examination, no deviation in angle of mouth, no drooling of saliva, no presence of swelling on the contralateral side, no other swellings noted in the neck. There was no difficulty in opening and closing of the mouth. Examination of the oral cavity on inspection, normal oral hygiene, no discharge noted near the right parotid duct opening. There was no visible swelling displacing the right tonsillar pillar. An examination of the facial nerve was carried out separately to test the superior belly of frontalis by asking the patient to raise eyebrows. A wrinkling was seen. Orbicularis oculi showed no weakness of the muscle. Buccinator, platysma, and levator anguli ori, all muscles were intact on examination. On palpation, inspectory findings were confirmed on palpation. There was no local rise of temperature over the swelling. It was a non-tender single swelling of 4 into 4 centimeter, palpated in the right parotid region with well-defined margins, lobulated surface, firm in consistency. There was no fluctuation. Skin was not fixed to the swelling, not fixed to the right masseter muscle. Curtain sign is positive. Right parotid duct is normal on palpation. Right parotid duct opening is normal and no discharge on bidigital examination. On bimanual examination, no fullness palpable in the right tonsillar pillar. Contralateral parotid gland was not palpable. There was no palpable preauricular lymph node, no cervical lymphadenopathy, and no enlargement of the submandibular or other sublingual salivary gland. Systemic examination, respiratory system bilateral air entry was positive with no adventitious sounds. Cardiac system S1, S2 heard, no generalized lymphadenopathy, no neurological defects, and motor system was normal. At the end of my, to summarize, 52-year-old lady with nil comorbidities and no previous surgical history with a 4 into 4 centimeter single, slow growing, painless swelling in the right parotid region with normal duct opening, with no features suggestive of deep lobe involvement, malignancy, facial nerve involvement, lymph nodal spread, or contralateral parotid duct involvement. Sir.
Dr. Naim, could you go back to your first slide of the examination? Okay. First of all, you never say that vitals are stable. Just say vitals are normal. Obviously, they'll
Yes,
be this thing. The patient is stable, vitals are normal. You don't have to give. Sorry, just go back. You don't have to give such a. No, the next slide, please. Such a precise. No, the next one. 0.5 centimeter, 1 centimeter, 2 centimeters. You said it's the parotid region. We all know about it. Okay. Right. Obliteration of the retromandibular groove. Why does that happen?
Sir, the parotid is like an inverted pyramid, sir. The lower part would extend at that region, at the retromandibular groove between the mastoid and the angle of mandible. So if it's a large enough swelling, it will obliterate the retromandibular groove, sir.
So the parotids, the superficial and the deep lobe, they are covering the mandible, and that's why. Okay, next slide, please.
Yes.
No difficulty in mouth, no other swelling. Examination of. Okay, next slide. Next. You said bidigital examination for parotid duct and bimanual examination for tonsillar pillars.
Yes.
So what's the difference between bidigital and bimanual?
Sir, the parotid duct is located and approximately right below the zygomatic arch. So with the same finger, if we roll our finger on the cheek, one finger inside and one.
Can you do it with the 2 digits, or you can roll it like that?
Roll
what about bimanual for tonsillar pillars? Can you put your both hands inside?
Actually, sir, only if we see on inspection there is some enlargement of
right.
the.
So there's nothing called bimanual.
Yes, sir. Yes, sir.
What is curtain sign? Positive. You said curtain sign positive.
Sir, the parotid is enclosed by a parotid fascia, which has a superficial and a deep layer. The superficial layer goes and it attaches to the lower part of the zygomatic arch. The importance of this sign is that any parotid swelling, it cannot be moved beyond the zygomatic arch, and that would give us a clue of where the swelling is arising from, if it's parotid or
and suppose it crosses the zygomatic, then suppose the swelling crosses the zygomatic,
then it must be other than parotid, sir. Most likely.
What other
like
than
what? Other than parotid means what?
Right from the skin, we could say that if it's like a dermoid cyst or
So your answer,
Sorry,
Dr. Naim, Dr. Naim,
stop.
answer
lipoma.
would be that it was superficial to the deep
Superficial to
cervical fascia.
yes, sir.
That's it.
Uh,
Don't say
Dr.
skin,
Naim,
subcutaneous tissue, start naming all the muscles, the swellings.
Superficial to the
Next
deep.
slide, please.
Dr. Naim, like what
Sir, I would like to ask something.
Sir, please.
You have written right parotid duct is normal on palpation. How did you palpate right parotid duct?
Ask the patient to clench the teeth, so the masseter becomes taut, and against the anterior border of the taut masseter, just below the zygomatic arch, if we palpate, we can palpate the parotid gland to give an anatomical location. We would say from the.
Have you palpated your parotid duct?
Yes, sir, I can. On just against the masseter, sir.
Oh, no. Sorry, Dr. Naim. A normal parotid duct cannot be palpated.
Exactly. That's what I was asking.
You
Right?
can never.
It's only an abnormal duct which will be palpated. You can't palpate a normal duct.
It's very, very rare to palpate in some very thinly. So you are able to palpate in this patient, really?
She's not a thin lady. She's the.
Second
also,
point.
Parotid ducts, very difficult.
Second point is, what is length of parotid duct?
So it is 5 centimeters in length.
Okay. So out of 4, actually it is 4 centimeter, 4 to 5. It's okay. I will give it to you. How much parotid duct is palpable, if it is palpable?
You have already 4 centimeter mass is there.
Anyway, it is rarely palpable, and I would not say, unless it is palpable, you don't mention about it. That's what I'm trying to tell you.
Yes,
right?
sir. Yes.
What do you mean by no discharge on by digital examination? What is meaning? I did not get that meaning.
So if it is a parotid fistula opening into the parenchyma.
Is it parotid fistula?
No, sir.
So why there is no parotid fistula in your whole examination? So why you are examining for parotid fistula?
There can
you
be.
have written about duct. Duct opening is normal, no discharge on bidigital examination. What is meaning? What do you mean by bidigital examination?
Between the digits of the finger, if we examine.
That is the normal way to. So you want the discharge to come from a parotid duct opening. Am I right? That's what you are trying to tell. So how will it? How the bidigital will do it? There is some other method to do it. What is the method to do that? Do you know or not? If you don't know, say
any massage.
Massage. You understand? You massage the external parotid opening. Suppose you massage and see the pus discharge. Will it change your diagnosis?
Yes, sir.
How will it change your diagnosis?
If there is plurulent, if there is discharge, then it would. I don't know, sir.
So the point, what I want to impress from beginning, you have too much prepared and only one thing, it is a pleomorphic adenoma. You are not thinking of any other thing. Do you understand? Suppose it is an inflammatory tumor, right? So which are the common inflammatory, not tumor is a wrong word, inflammatory swelling in parotid? Which you have looked at.
Parotid
Abscess will not come in your exam. Don't say parotid abscess first. So what I want to impress, don't be carried away that it is pleomorphic adenoma, and I will be asked question on pleomorphic adenoma only. If examiner is like me, I will not ask you a single question about parotid pleomorphic adenoma. So can any viral infection cause parotid swelling?
Yes, sir. Mumps is the mumps.
So what will be the presentation in mumps?
Sir, history of most commonly bilateral parotid glands are involved in mumps. A short duration of painful bilateral swelling will be present with the associated
Got
fever,
it.
sir.
Got it. Right? At which age
Yes, sir.
mumps is common?
In childhood, sir.
Can it occur in adult?
Yes, sir. Can.
It can, and it will be more severe when it occurs in
Yes.
an adult patient. And
Yes.
it is bilateral, but not necessarily simultaneous. What does it mean?
One after the other gland.
One after the other. So patient can present with unilateral swelling. Any other inflammatory swelling?
Sir, inflammatory swelling, ascending parotitis, sir, in elderly.
What is, sorry, what is ascending parotitis?
Bacterial ascending parotitis.
From
sir,
ascending from where? Ascending from where?
It's a new terminology. Eh?
I'm really surprised the depth of your knowledge.
Acute parotitis, sir, in elderly patients. Acute parotitis.
Ascending, there is something new I have learned today. Anyway, parotitis, or better word is siloadenitis.
Siloadenitis.
Right? Siloadenitis. So keep the other things also in your mind. That's what I want to do. Next slide, please.
What is the plane of the swelling?
Sir, deep to the deep fascia, sir.
You said the deep fascia encloses it.
Yes, sir.
And how can it go deep to the deep fascia?
Sir, in my swelling, when I asked the patient to taught the masseter,
it was splits to enclose the parotid gland.
Yes, sir. It splits to enclose the parotid gland.
So you say it's within.
Yes, below the deep
within
fascia.
the deep
Yes.
fascia.
Within the deep fascia.
Go ahead, sir. Is asking.
So
No,
fullness,
yes,
sorry, fullness of
it,
tonsillar, it is more visible than palpatory. Okay, so it's not palpatory finding; it's a visual finding.
No, there is no lifting of the air lobule. There is no preauricular. Retromandibular groove is not obliterated. Why not? It is a preauricular node. You said no palpable preauricular node. I am saying this swelling itself is a preauricular node.
It could be, sir. But lymph node, if it's a preauricular lymph node, it will have a little more mobility, and curtain sign will not be there in a lymph node.
See, how long you cannot bring that to the forehead?
There can be lymph nodes within the lymphatics, lymphatics within the parotid. They can also be swollen, affected, right?
Yes, sir, they can be.
With a lymphatic involvement of the lymphatics within the parotid. Okay.
Yes, sir.
Okay, next slide.
How will you differentiate then?
Sir, if it is a intraglandular lymph node involvement, I think it would be difficult to differentiate because it is in the.
Okay. If you are putting the fascia into thought, what will be happening with the parotid and what will happen to the preauricular?
Sir, if it's a parotid swelling, it will become more prominent, sir. And if it is a lymph node, if it's an intraglandular lymph node, we won't be able to differentiate. If it's a preauricular lymph node, there'll be no change in the size. Okay. No change in the size if it's a preauricular.
Putting the muscle into contraction, opening the mouth, or clench the tooth, then movement will be restricted.
Yes.
In the parotid, you will not be able to move. In a preauricular node, it is not within the deep fascia, so it will be superficial to that. You can easily move that.
Yes.
So there are options to find out whether it is a preauricular. Of course, it cannot be possible. Intraglandular, it is you can't make it out.
Okay. Yes. Here you have written no enlargement of sublingual salivary gland. How did you come to that conclusion?
So on the floor of the mouth, if there is some.
So how many times you will find? I have never seen in my life visible or palpable sublingual salivary gland. It is almost always incidental or accidental. And you are categorically saying there is no enlargement.
Yes, sir.
So don't put too much stress on that. Salivary, submandibular, I can understand. Sublingual, you can say it is not palpable. I don't know. I don't know.
Yes.
Dr. Naeem, actually what has happened that you have tried to put a lot of information into your findings, right?
Yes.
Had you just said no other lymph glands are palpable,
that's it.
This question would have come.
Yes.
I tell you, in the exam, we should not put all the information in one go. You should let the examiner ask you and then
Yes.
give the information. Okay. So
Each
that is a better way of.
You are talking about preauricular node and with related to the parotid. Suddenly you are being second line is no cervical lymphadenopathy. No. You go by a systematic approach. Other oral cavity you have not examined.
I think
On
she
the
has. Go one slide
opposite-
back. Jailal sir, I think she had examined. I wanted to ask something. Yeah. No, there was something. Later on, I don't know. Intraoral, I had seen. Go one slide further. Next. No. So sir is asking very important. I thought I saw it. Bimanual. You were doing something about bimanual. Go back. One slide further. So this is what she had said. Actually, it is incomplete. Do you understand? Bimanual examination. What is that? Sir was
if
also
there
asking
is
the same question.
Deep lobe of parotid gland involvement, sir, there will be fullness that will be palpable in the right tonsil, in the tonsillar pillar, sir. If it's
In
very
the
large,
tonsillar pillar or anterior wall of pharynx or lateral wall of pharynx, what would you like to say?
Along lateral wall of pharynx.
Okay. So if you palpate fullness, what will be your conclusion as you have said?
Deep lobe involvement, sir.
I don't know. I'm asking you.
Deep lobe involvement.
No. So, okay. If you find deep lobe is involved, so what will be your diagnosis then?
So benign swellings can also reach large sizes where they can involve both the lobes, less commonly, but it is possible. And if it is a malignant swelling, then it will be large size involving both the lobes of the parotid.
Okay, Dr. Naeem, why is the deep lobe less commonly involved?
Yes, that's actually I was reaching to. Good.
Why do you think it's less commonly involved? I'll give you a hint. Which quadrant of the breast has the maximum amount of chance of
Carcinoma breast.
involvement? Or which lobe of the liver?
Right, because of the size, superficial lobe has a bigger size, and
How much bigger?
But the majority of the tumor, the
80% of
superficial.
Yes.
80% of the
That's the
parotid
answer.
gland is the
So straight away
superficial.
80% is gone.
Yes, and 20% is the tumor.
So what the sir was asking, bimanual means it is not only oral cavity as a whole. You understand? You should examine that whether there is any dental caries there, submucous fibrosis is, what is the amount of opening of the mouth, which will be included part of. So you should have a separate rather than all this examination of oral cavity or palpation of oral cavity, which is very important in parotid.
So you are talking about sublingual gland, then you should talk about the lingual tongue, tongue also. So all that is part when you are saying oral cavity.
Movement of the tongue has not been discussed at all. Your examination of the tongue has not been done there at all. So your cranial nerves involvement, you have not been able to elicit.
Okay. I think we go further now. I think time is okay. Next slide. Okay.
Which cranial nerves would you be?
So my provisional diet.
No, sir is asking something. Go back. Yes.
Which cranial nerves would you be interested in?
So first and foremost, because of the anatomical proximity, facial nerve, and then others like the mandibular, the 9th, 10th, 11th nerve, base of the skull, nerves that arise from the base of the skull.
Okay. 7, 9, 10, and 11.
Yes, sir.
Right.
And the fifth cranial nerve. The fifth, how do you check the fifth cranial nerve? And its branches.
How do you test for the fifth cranial nerve?
So,
which is the fifth cranial nerve, please?
Trigeminal, sir. Trigeminal with its 3 divisions: maxillary, mandibular, and ophthalmic, sir. So test related to.
Which is motor? You have 3 divisions, no? Which is motor then?
Which one is
so
motor?
the mandibular division, the mandibular division.
Mandibular division goes for anterior and posterior, no?
Posterior division of the mandibular nerve is the motor nerve. Sir.
posterior is more of parasympathetic supplying. It supplies the parotid gland also. So it is a posterior division. It is more what? What is it?
So auriculotemporal is the parasympathetic supply, sir.
And auriculotemporal is branch of
Mandibular nerve, sir.
which, anterior or posterior?
Posterior division of mandibular nerve.
That's what the sir is asking.
Yes.
So from where does the parasympathetic supply comes for parotid?
Sir, the parasympathetic is the secretomotor supply for the parotid gland. It's related to the nuclei present, inferior salivatory nucleus in the medulla, which is relayed through the glossopharyngeal ninth nerve. Its preganglionic fibers are relayed through the glossopharyngeal ninth nerve and through the tympanic plexus, and it gives off the lesser petrosal nerve. Which relays
So
in the
where does the lesser petrosal join the auriculotemporal?
sir, at the otic ganglion, sir, its fibers get relayed, and from that auriculotemporal carries the postganglionic fibers, sir.
Okay. I think you
And
know it well.
Can there be
Okay,
greater
next
auricular nerve involvement?
Diagnosis.
Can there be
Sorry,
a greater
sir?
auricular nerve involvement in this patient? Greater auricular nerve.
Yes.
How do you go for that?
Sir, there are interneural connections, sir, between the facial nerve and the mandibular nerve and the
No,
auriculotemporal.
He's asking
No,
greater
I'm
auricular
asking about
nerve.
greater auricular nerve.
Yes, sir.
Greater-
Greater auricular nerve is the sensory supply of that area, sir. It can
What
be
area?
involved.
What area, ma?
Sir, around in front of the ear, preauricular region, postauricular region, and also upper part of the neck, sir, around the upper part of the neck on that.
Is that a branch of cranial nerves, or is it not a branch of cranial nerves? The greater auricular
No,
nerve?
sir. It is a spinal branch, sir. The anterior rami of cranial spinal nerve C2 and
Spinal-
C3, sir.
C2, C3, cervical
C2
plug.
and C3.
What difficulty will come when you injure the greater auricular nerve?
Sir, there will be sensory loss over the
What sensory
area in
loss?
and
What sensory loss will be there?
touch, sir. Touch, sir.
No. It is very sensitive for the cold, temperature and cold. So it is only problematic for the people who are going for the scuba diving, especially when you are dividing the posterior division of the greater auricular nerve. Other sensation will not be lost. So when the cold temperature variation sensation is mainly by the greater auricular nerve, which they will not be appreciated for the people who are going in the scuba diving.
Okay.
Then men who
Dr. Naik.
shave themselves, they might cut themselves while shaving and not notice it if the greater auricular nerve is injured. That is another
Yes.
way it can present. Cuts during shaving might go unnoticed by those who are shaving, because that the area which is being shaved has lost sensation.
Okay, Dr. Naik. Now, how will you proceed? You've got this patient.
What's the diagnosis? You put the diagnosis, no?
Sir, my just based off my clinical examination, my provisional diagnosis would be a right parotid tumor, most likely benign, most likely a pleomorphic adenoma, with no involvement of facial nerve or no lymph nodal spread, sir.
Okay. How will you proceed now?
Sir, I would first like to confirm the anatomical involvement.
Have
by
you had
ad-
any condition of pleomorphic adenoma involving the facial nerve?
No, sir. Less
Of course it
likely.
can.
involved.
No, it
No,
can.
you already made a diagnosis of pleomorphic adenoma. Then why you are very particular? There is no involvement of the facial nerve.
So
Okay, tell us when facial nerve would be involved in a case of pleomorphic adenoma.
very large swellings can actually involve
No.
the facial nerve, sir.
No,
If it
look,
infiltrates.
facial nerve is an No. Facial nerve has to be infiltrated to be involved,
Yes, sir. It has to be.
right?
So when will it
infiltration
get
will not
into
happen
it?
by large benign tumors.
So benign, rarely, but benign converting into having a malignant transformation
Right.
will.
That's what the sir is
Pleomorphic
asking.
adenomas, when they
facial-
convert into malignancy, they will
malignancy.
involve the facial nerve.
Yes.
Okay, Naeem, I would
Yes.
like to ask, what are the other differential diagnoses? Have you put any differential diagnosis in this patient?
No, sir. But
Why not? Can it be an intraparotid lipoma?
yes, sir, it can be intraparotid lipoma. Apart from that, it can also be.
No. Let us stick to lipoma. Don't give too much of theory to me because I don't know much theory. What will be the presentation in intraparotid lipoma? How will you differentiate clinically?
Sir, the size can be, the size is
Any
not
size.
a factor.
Size is not an
Can be
issue.
any, yes, sir. And it's not, it's superficial to the deep fascia, sir, not attached carotid.
Sorry.
Intraparotid. He asked a very
I am
particular
talking of intraparotid.
Sorry, intraparotid. Intraparotid lipoma.
I know. Once you become a surgeon in this many years, I am surprised many times, considering it to be parotid edema open and turn out to be lipoma. Pleasant surprise. So remember, that is always on the card. Why the lipoma in a parotid will not present like any other lipoma? What is something special about parotid?
What? Sorry, sir.
What is something special about parotid? It is covered by very strong, thick parotid fascia. Which is extension of.
So the inferiorly continues with the
No. It is extension of which fascia?
investing layer of deep cervical fascia.
Cervical fascia. So it is very difficult to differentiate lipoma. There are certain things, but keep this. Which other benign swelling you will think of? Give me one by one. Don't give me list. Any others benign swelling which occurs in parotid?
Why not? It is a Warthin's tumor.
So the age group of Warthin's is more elderly, 60
More
years,
elderly.
and male patients have a more predisposition to develop Warthin's, sir. And
I agree to that. Yes.
Smoking would also be.
Which pole you normally get?
Yes.
Sorry, sir.
Which pole of parotid?
Lower, sir. Lower pole of parotid would be involved, and one more point, it's more in smokers, smoking would also be a
According to your clinical finding, it is a 4x4 smooth lobular swelling. No, that fits into an Warthin's tumor than a pleomorphic adenoma.
Dr. Naim, you should stand by your diagnosis. If sir says he's trying to convince it's Warthin's, are you convinced it's Warthin's?
No, sir.
No, then you tell him.
Why not?
Tell him that. Why not? Tell him give him your points.
Sir,
why it's not Warthin's?
Higher age group, male predisposition.
No. Hang on. Most common. Warthin's is a rare tumor.
Yes, sir. Warthin's is
first
rare.
thing. So I'll think of the most common thing first.
Yes.
Then comes all those age and male and smoking and all that nonsense.
Bilateral.
Just tell him.
Yes, sir.
So we want you to open up. Don't be very. I will say only this thing. I know it is not lipoma, but always think of this. What I was aiming is pleomorphic adenoma, Warthin tumors, lipoma, and there are possibility lymphangioma is also one of the presenting tumors. Similarly, we have seen hemangioma and AV cavernous hemangioma and AV malformation in parotid. Though they are rare, there is a different type of presentation, but keep these swellings in your mind. Don't think that what you have presented will say only pleomorphic. Examiner is free to ask anything. He should be ready. So be more practical. Don't give theories. Okay, please.
In the children, if you talk about that turkey wattle sign or the hemangioma is one always you should consider.
Okay.
Okay, FNAC or no FNAC?
Dr. We can do FNAC in Peru.
I can even do an incisional biopsy. I can do everything. Will you do it or not do it?
Yes, sir, I will.
If you do it, yes. If you won't do it, why?
You do plain FNAC or ultrasound guided FNAC?
Ultrasound guided FNAC, I would do so.
Okay, why do you want an FNAC? Why do you want an FNAC? In this patient, do you want it or you don't want it?
To know the histology of the swell.
Will it change your management? Will it change your management?
So it will give us a clue to the histology of the swelling, sir, whether to
My
confirm that
question
it
is-
is a benign.
No. My question is, suppose it comes out as pleomorphic. Fine. I think also it's pleomorphic. How has this FNAC report helped you? Has it helped you or not helped you?
If it comes as walk-ins or if it
If
comes
it comes out as, sorry, sir.
if it comes as a walk-in tumor or if it comes as a pleomorphy, is there any change in the treatment?
Benign, if it comes out as benign, there would there would not be a
Definitely, there is a, your approach is different for Warthin's tumor and pleomorphic adenoma.
Dr. Naim, this is what I want to stress. If you think FNAC is required, you tell me. There are two schools of thoughts. Yes for FNAC, no for FNAC. Okay, ultrasound, yes, no.
FNAC and ultrasound guided ultrasound as well as FNAC should be done, sir.
Okay, CT scan, yes, no.
Only if there is deep lobe involvement, infiltration of facial nerve. If it is a recurrent
No,
parotid,
hang on. Will CT tell me infiltration of the nerve?
MRI would be better to find out infiltration.
MRI, not would be better. MRI is the
standard
investigational choice.
yes.
Right. Okay. So here, with no facial nerve involvement, with nothing there, I won't go in for FNAC. I won't go in for a CT scan. What is the minimum biopsy for a parotid?
Superficial parotidectomy with
Right.
conservation of facial nerves, sir.
Right. That is an okay. So it's superficial parotidectomy, right?
Yes.
So that's what we have to do. Now,
Yes.
what is superficial parotidectomy?
It's a removal of the superficial lobe of the parotid gland, sir.
What is superficial over the parotid gland?
Over the parotid gland, sir.
What is superficial over the parotid gland?
The parotid
All the tissue,
fascia,
superficial
skinny
to
subcutaneous tissue.
all the parotid tissue,
Deep
superficial
investing layer
to
of deep cervical fascia.
no.
Investing
What is the
layer
plane?
of deeps.
What is that
No.
plane in which you are saying
What
supervision?
is the plane? Patties,
Patties plexus, nerval venous
Fasciovenous
plexus
plane.
of plane of Patties.
fasciovenous
Facious
plane.
venous plane of
Patties.
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 What
Plane
are
will be there.
what are the
Ret-
vessels which are present in the plane? Patties. Fasciovenous plane. Name the
Patties is
vessels.
branching retromandibular vein branches, sir.
How it is formed?
And,
How is?
Retromandibular vein is formed.
So it is formed by a combination of the superficial temporal as well as maxillary vein, which forms the retromandibular vein.
How it continues?
And anterofacial vein also. And anterofacial vein.
How it continues? Retromandibular vein.
It continues below to divide into anterior and posterior branches, sir. Anterior branch joins the facial nerve to form the internal jugular vein, and the posterior branch joins the posterior auricular vein to form the external jugular vein, sir.
Good.
Who was Patty? Who was Patty?
Who was Patty?
Patty. Patty is fasciovenous plane. Who was Patty? I think it's not okay. Fine. Forget it. Just somebody, he was a renowned surgeon, UK. Actually, he operated upon Queen Elizabeth for superficial parotidectomy, and she had a transient facial nerve pulse.
Okay, Dr. Naim, what is the incision given for?
and I think she described the mastectomy operation also. Patties modified radical mastectomy.
Yes, sir.
So what's the incision given? What's the incision made?
So it's
For
the
parotid surgery?
modified Blair's or lazy essence.
So what modification? What did Blair do? And what was the modification done?
So Blair modified it to have a cervical
No, Blair didn't modify.
extension,
Blair
sir,
gave the
to
incision.
expose.
Sorry, Dr. Naim. Blair gave the incision.
Yes.
It was Bailey who
Bailey
modified.
Bailey. Sorry, Bailey.
So what was the
modified it.
modification? So what was the modification?
Sir, to include the extension to the cervical part to expose the lower part of the gland and the sternocleidomastoid, sir.
No, actually, Blair gave a vertical incision. It was
Yes.
it was Bailey who gave that lazy ass incision,
Yes.
right? Because it was okay. So the whole surgery about parotid is about facial nerve, right?
Yes, sir.
Isn't it? So how do you
Yes.
identify the facial nerve?
Sir, there are two approaches that we can use. The most common approach used is the anterograde approach, sir, in which the facial nerve branches are traced from the main trunk to the peripheral branches. There are few certain landmarks that can be given, that can be found intraoperatively. First is just above the posterior, just 1 centimeter above the posterior belly of digastric, sir. On its attachment to the mastoid. Second would be the tragal pointer of Conley, sir. Then others, these are the most common, and others would be
Okay.
uh,
The facial nerve emerges from which
kind of
foramen?
stylomastoid foramen, sir.
And then what happens to it?
So it gives off motor branches to the styloid, to the posterior belly of digastric, and also it then branches into two main trunks, commonly the temporofacial and the cervicofacial, after which more subsequent branches into 5 motor branches: the temporal, the zygomatic, upper and lower buccal, marginal mandibular, and cervical, sir.
So complications of surgery, which is Professor Rajgopal's favorite mnemonic. Complications of parotid surgery.
I don't know the mnemonic, sir.
Okay, give us the complications.
He is there to give it.
Yes, bleeding.
Bleeding is not one of them. Hardly. We don't find much of
Sorry,
bleeding.
sir.
Bleeding कहाँ से होता है parotid में? Where do you find bleeding? Bleeding from what?
Sir, if
parotid.
branches of stylomastoid artery, which are close to the facial nerve, if they are
okay, post-op is hardly. Okay, others.
Postgraduate, you must say only the salient features. Don't try to go into routine. Bleeding is a complication of any surgery.
Yes, sir.
The most common complication of parotid surgery is what?
So most common would be a sensory loss over the greater auricular nerve region, and a phrase syndrome can also happen.
It is facial nerve damage.
5F.
It is facial nerve damage. It's the most common complication.
Yes.
Right? Auriculotemporal, all that greater auricular is fine. It's facial nerve. Second is what? Give us according to what is more commonly seen. You must have seen a surgery for parotid.
Yes, sir.
Have you?
So flap necrosis.
Okay. That's also rare.
And it was in old incision, it was common. Sistrunk and Blair. In modified lazy S, it's not that common. Agreed.
Which is a common.
Yes.
You worked as a resident. You must have seen your boss doing a parotid. What did you see the next day? You check for the facial nerve.
Angles
what else did you check for?
Angles of mouth and what?
That's fine. You check for the facial. That's done.
Yes. Sir.
Next.
Yes, sir.
Next, what did you check for? Was there a drain put?
Yes, sir. Drain.
So what is that for? Fluid collection. So you have one F facial. The second F is fluid.
Hematoma, sir.
1/3 you said.
Yes.
One you said flap necrosis.
Yes, sir.
What is the fourth one?
Hematoma, sir. Hemorrhage.
Hematoma. We've ruled it out.
Yes, sir.
What is the fourth one?
I was asking about that questions previously.
Yes, fistulas. Right?
Fistula. Yes, sir.
Right. And the fifth is Frey syndrome.
Frey syndrome, sir.
So you have 5 Fs.
Yes.
Right?
Yes.
Can you rattle them off now?
Yeah. Why this is called as a mixed parotid tumor or pleomorphic?
Sir, it contains myoepithelial, stromal, as well as cartilage component.
There's no cartilage component here.
So it's
Doctor name?
it's pseudo cartilage, sir. Pseudo cartilage.
What is pseudocartilage?
Sir, the mucin that is secreted
Okay,
and the
that's it.
stromal
Is the
component
mucin.
gets inspissated as a cartilage, sir. Yes, sir.
Okay.
What is fistula? You were saying about fistula.
Sir, is putting as a time up.
Which type of fistula is common? Duct fistula or gland fistula? And what is difference?
Sir, duct.
Okay.
fistula,
Another question. I will ask another way. I will ask you another way. Let me ask the question. When you do superficial parotidectomy, what do you do to the duct? And what do you do to the deep gland?
And what will happen to the deep lobe when it is secretes?
Okay.
The deep lobe is not involved. In superficial parotidectomy, we don't reach.
And what happens to that? It has to have a salivary supply sending out. What happens to duct in superficial parotidectomy? That's what I'm asking. It is
Okay,
normal.
Dr. Naim, I'll give you a hint. You've removed the superficial lobe, right? But you have not tied the duct anywhere, have you? You usually don't tie the duct. Isn't it? Dr. Naim? Are you there?
She's
I think
gone.
we lost her.
Okay. I think anyway, the 1 hour is over. Dr. Kanagalu is also pressing that. Okay.
Yeah, Dr. Naim, are you there now? I think she's gone.
Okay. Thank you very much, sir. It's okay. So shall we proceed to second case now?
Yes, sir. I think we have Professor Gaurav Agarwal also has joined. Welcome, Dr. Gaurav Agarwal. Sir is a professor and head of the department from Department of Surgical Endocrinology and Breast Disorders, SGPGA, Lucknow.
Yeah, good evening, everyone. It's a pleasure to be
good evening,
connected.
sir.
Good evening, sir.
Good evening, Dr. Gaurav. Nice to have you here.
Yes.
Good evening, Gaurav.
Good to see you, sir, Dr. Alkanna, and of
Nice
course,
to see you, sir.
all the other stalwarts.
Dr. Naeem, can you please unshare your screen, ma?
She can't hear.
I think you will have to do it, sir.
Dr. Kiruba, please introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck to you. All the best.
Thank you, sir.
Thank you, Dr. Naeem. You please stay with us till the end of the session.
Good evening, sir. I am Dr. Kirba from final year postgraduate from Government Kanyakumari Medical College. I thank my HOD, Professor Dr. Zaila, for giving me this opportunity to present this case. Shall I start, sir?
Please, ma'am,
Yes,
please
please.
go ahead. Please share your PowerPoint and start your presentation.
A 53-year-old gentleman who is a
Anna, we are unable to see your PPT.
Hello.
Go to the first slide, ma'am. Yeah, make it full screen. Yeah, good luck.
A 53-year-old gentleman who is a resident of Vettuni, madam, a butcher by occupation, came with a complaint of swelling in the neck for the past 2 years. History of present illness: the patient presented with the swelling in the anterior aspect of the neck for the past 2 years, which was initially small in size, now had gradually progressed to attain a size of 6+5 centimeter. No history of pain over the swelling. No history of change in voice. No history of dyspnea. No history of dysphagia. No history suggestive of hypo or hyperthyroidism. No history of any other swellings in the neck. No history of loss of weight, no history of loss of appetite, no history of bony pain, no history of abdominal pain. Past history, patient is not a known case of diabetes, hypertension, bronchial asthma, or epilepsy. He had a history of right herniorrhaphy done 20 years back and left hernioplasty 4 years back. No history of radiation in the past. Personal history, he was an alcoholic and smoker for the past 25 years and a tobacco chewer for the past 20 years. His bowel and bladder habits are normal. Sleep pattern is normal. Family history, no history of any swelling in the neck in the family members. Summary, a 53-year-age gentleman presented with a complaint of swelling in the neck for the past 2 years, which was initially small in size and had now increased to attain the present size. No features of no history suggestive of hypo or hyperthyroidism or compressive symptoms, no significant family history. So
No, Dr. Dr. Kiruba, can you go back to your first slide, please? Okay, occupation, does his being a butcher have any effect on the diagnosis? It doesn't.
No, sir.
So this information is irrelevant. Okay. You shouldn't put irrelevant stuff. Okay. Next slide, please. Why do you ask for pain over the swelling? It's basically a thyroid swelling, isn't it?
Yes, sir.
So why did you ask for pain?
Pain can occur because of hemorrhage into the gland or in case of thyroiditis.
Right. Okay. What about dysphagia? Does dysphagia happen in a thyroid swelling?
Sorry, sir. Sir?
What's the size of the swelling? It's 6 centimeters, is it?
It's a 6 or 5 centimeters, sir.
Yeah, so it's. Do you have a picture of it? Okay, anyway. So dysphagia is uncommon. Sorry. Yeah, dysphagia would be uncommon because it has the esophagus lies behind the trachea, right?
Yes, sir.
So it's slightly uncommon to have dysphagia in a patient with thyroid swelling. Okay. A history of abdominal pain. Why do you ask for that?
To rule out metastatic history.
Any thyroid swelling which is associated with abdominal lumps?
So liver metastasis can occur in medullary
Okay,
carcinoma.
one is METs. One is METs, right? But are METs painful?
No, sir.
Right. So why did you ask for abdominal pain? Okay, so abdominal pain usually does not. What I would have asked him is that, does he have any swelling in the abdomen? Any swellings of the thyroid, which can be associated with swellings in the abdomen? What is Men's syndrome?
Like
Pheochromocytoma can be there, sir. If medullary men 2A and 2B, medullary
Okay, so there can be.
yes.
What abdominal symptoms can be reflective of the functional state of the thyroid gland?
Okay.
What abdominal symptoms might reflect the functional status of the thyroid gland?
Any change with the hypo or hyperthyroidism with abdominal function or abdominal pain?
The patient will have loss of weight and hyperthyroidism. Increased frequency of stools hyperthyroidism may be there.
Right. Okay. Next slide, please. Okay, history of radiation in the past. What would that give you information? Suppose there was history of irradiation. What swelling would you expect in the thyroid?
There's a chance of papillary carcinoma thyroid if there is history of previous radiation, sir. What will it take?
Okay, next slide. Next slide. Look, this person, alcoholic means what? What is the difference between consuming alcohol and being an alcoholic?
That consumes daily for years, 25 years.
No, if he's dependent, he can't live without alcohol, this alcoholic, right? Just consuming alcohol doesn't make him an alcoholic, right? So you just write he consumes alcohol.
Okay.
Right?
Only one person has a physical dependence for alcohol, then it must be put as an alcohol.
Right? Okay. Family history. How do you ask for family history? What family history are you looking for? Which are the tumors of the thyroid which are familial?
Sir, MEN 2A and MEN 2B, MEN syndrome is familiar, sir.
I'm asking you what is thyroid swelling, not MEN syndrome. I'm asking for thyroid swelling. No.
It can be endemic goiter.
Okay, what is endemicity? What is endemicity?
So many people in one location.
How many people? How much percent of the population should be involved to call it an endemic?
That is standard definition for endemicity.
More than 10.
Yeah, 10%.
10%.
Okay. Right. So that's one thing. Familial thyroid swellings. Give me most common. Quickly. No, medullary carcinoma of the thyroid. Right? That's familial, usually, isn't it? If you have someone having medullary carcinoma, we examine the relatives, the first degree relatives for it. Okay.
In the family also, you need to classify whether it is environmental factors involved or genetic factors. You see, because family members might be exposed to the same environmental condition. That is one condition which could be familiar. The other situation could be that they are sharing the same genetic abnormality. So you need to classify your familiar condition into these two groups.
Okay, can you tell me which is the gene most common involved in genetic forms of
ret oncogene, sir?
Ret oncogene, BRAF. BRAF, okay, and ret oncogenes. Okay. Next slide, please.
All you must know all for each. So if you say papillary or medullary, each oncogene is different. RAS is something. P53 is also important for anaplastic carcinoma.
So what's the diagnosis by your history? Dr. Kiruba, what do you think is your diagnosis? You've got a swelling on one side of the neck.
It's a solitary thyroid nodule. Patient in euthyroid state. It could be benign or malignant, sir.
No, first, is it benign or malignant?
Sir, it's because of male patient. I suspect malignancy also in this patient, sir.
No. I mean, just because it's male doesn't make it his swelling malignant. What are the features of a malignant swelling of a thyroid?
Clinically, if there is associated, the nodule is hard in consistency. There is presence of cervical.
No, I'm talking by history.
History. Rapid increase in size of the swelling. Males
okay, rapidly increase in swelling. Right, males. Okay.
Then associated compressive symptoms or nerve involvement, presence of nerve involvement.
Infiltrative symptoms are very important. Compressive, even a large benign thing can cause compressive symptoms, but a benign condition never causes an infiltrative symptom, right? So the infiltrative symptom would be change in voice.
Change in voice.
Right? And of course, if there are any other swellings in the neck,
other swellings in the neck or bony swellings, then there may be family history.
Okay, that's fine. So should we move to examination, please, sir?
So from history, what do you think? Is it benign or malignant?
The based on history, it's benign.
This patient, benign. So the title is carcinoma doesn't mean it has to be carcinoma. Do you understand?
Yes.
So from history, it looks, except one more point is size. And right. Okay. Next.
What percentage of, I mean, you are not said solid or thing. Okay, go ahead to the examination, inspection. Okay.
Examination of the general examination. Patient is conscious, oriented, afebrile. ECOG score 0. Patient is well built, well nourished, not anemic, icteric, no cyanosis, clubbing, or generalized lymphadenopathy. His vitals are normal, BP 120/80, and pulse rate was 78 per minute, a normal volume. Shall I go? Examination of thyroid region. After getting informed consent in a well-lit room, I examine the patient. After exposure, a swelling of size 6 × 5 cm is seen in the thyroid region, right of midline. It moves with deglutition. A lower border is seen. Trachea shifted to the left, and trial sign was positive. Skin over the swelling was normal. This is the image of the patient.
What do you mean by trail sign?
So there's a prominence of sternocleidomastoid on the opposite side.
Can you show the cursor? Can you show it with the cursor? Right. Why does that happen?
There is a nodule is pushing the trachea.
So the trachea is pushed below the,
Sternocleidomastoid.
and that makes the sternocleidomastoid taut.
Prominent.
Taut. So
You've taken this clinical photograph, but the mask of the patient is coming in front of the thyroid swelling. So that's not the appropriate method. Okay. And the shirt also should have been off his shoulders. So we would have been able to appreciate the full extent of the swelling, including the
you said he
sternocleidomastoid.
exposed the patient, but your photograph is not showing the patient exposed properly. Okay.
This
Exposure is not adequate.
I didn't take during examination, sir.
So, okay. Go on.
On palpation, inspectory findings are confirmed. The surface is smooth, firm in consistency.
What inspectory findings did you confirm? What
Sir,
inspectory findings did you confirm?
a swelling of size 6 × 5 cm seen in the right lobe of thyroid, which moves with deglutition. Surface is smooth, firm in consistency. Trachea shifted towards left.
Sorry, Dr. Kiruba.
Yes, sir.
Moving with deglutition is not a palpatory finding, please. Okay.
Okay.
Yeah.
Coccus test was negative.
Here you have written what is meaning of non-warm.
Sir, it's not needed, sir.
Then it is needed, but not warm. What is the normal temperature of body you will call? Warm.
Is
So
it
it
warm?
is cold
Normal
swelling?
body, is it warm or is it cold?
Warm, sir.
Normal body is warm. Okay, Kiruba.
Yes, sir.
Normal body is warm. So just it's not raised. It's not.
So the problem is that in some books, just to make it catchy, they write down non-tender, non-warm. Don't fall for that.
Yes,
There
sir.
is nothing like non-warm. It's actually warm. So you should say temperature is normal or not elevated or decreased. Temperature is normal. It is non-tender. Do you understand?
Okay, sir.
What is Cocker's test?
The slight compression of the lateral lobe of the lobe thyroid can cause stridor in a patient. Called Coccus test.
Why does that
Which
happen?
lobe did you compress in this case?
Right lobe, sir.
Right lobe. Okay. So what does it mean? You compress the right lobe.
What? Right. And the patient has stridor. So what is the point of doing it? Why do you do it? What information do you get?
Trachea is uncompressed, and there is a risk of there's tracheomalacia, and there is a risk of collapse of trachea after surgery.
Right. So this is that the trachea rings are weak, right? The chance of tracheomalacia is the high.
Yes,
Okay.
but it is normally occurs in a large bilateral swelling. Over the period of years, in a short 2 years of history, you don't find trichomalacia. And usually it is performed in a bilateral swelling. You compress on one side, still there will be a stridor. It suggests the rings are weaker. In this patient, I don't find any reason to do Cocker's test. Is the swelling... Please.
If I have to add one more, sir, whatever Modi sir told now, it is a classical finding. If there is a compression by your test now, it happens in the post-operative settings. When you remove the both lobes, then suddenly trachea loses the support. That is the time this. What if they already got a trichomalacia? Then it goes for that classical, finding for stridor. Yes.
So
Okay.
what is this trachea called? This type of trachea called? If the both lobes are pressing it, what is it called?
Scabbard trachea.
Scabbard.
Well, if I may
Please, sir.
intervene here. Well, the classical teaching is now that you do not elicit Cocker's test.
Yes, sir.
Please do not do it. It is inhumane. It's like strangulated a person. And as the case has been made by other experts, it doesn't help you arrive at any meaningful conclusion.
Okay.
And scabbard trachea is not a clinical finding. What do you mean by scabbard? What is the literal meaning of scabbard?
What is the shape?
Sword of Tipu Sultan.
Cover of a sword.
Excellent.
Myan bolte hai usko.
Myan. So scabbard trachea is a radiological finding. When you see on an X-ray, the air column looks like a scabbard shape. So it's not a clinical finding. You can't see it. You can't palpate to make out a scabbard shape. It's a radiological sign. Okay. We go back to your presentation. You've written the bilateral carotid left. What does that mean?
Felt, sir.
Felt. Oh, I'm so sorry. Felt. Bilateral carotid felt. Was there? Okay. And then right carotid pulsations are displaced laterally.
Yes.
At what level in the neck did you palpate for the carotid pulsations?
Sir, at the level of upper border of thyroid cartilage, sir. It's at the level of common carotid artery before bifurcation.
Against which? Against
C6 tubercle. Chesegnax.
tubercle of what?
Chesegnax tubercle.
No, name the C6 is a vertebra. So against vertebra do you palpate?
No, sir.
Against?
Tubercle, sir.
But tubercle, where is it situated?
C6.
Transverse process.
Transverse process.
Transverse process, C6 vertebra, tubercle. Sir, please continue. Sir.
Please go ahead.
Okay, what do you
said
mean
this-
by right carotid is displaced lateral?
Carotid is felt close to the sternocleidomastoid. Displaced laterally, sir.
Upon what is meaning of that? What does it give you? Information does it give you?
The thyroid gland is pushing the carotid.
Agreed. Anything else? The classical teaching, which I don't know whether sir will like, Barry's sign was very popular to ask.
But
We'll not go in detail of that, but what does the displaced laterally carotid pulsation literally means?
sir, in Berry's sign, there will be no pulsation. Pulsation will not be felt, sir.
And here it is felt. So what does it mean?
Sir, there's
Make
no
it right or wrong, that's a different thing.
listen. There's no infiltration of layers, tunica media of the vessel, sir. If it involves pulsation, will not be felt.
By media?
Oh,
I don't
so
know.
don't make it so complicated. All it means is that if you can palpate the carotid pulsations displaced laterally, it is only pushed. If you cannot palpate them, then it is encircled. It is if there's an
Encased.
infiltrative carcinoma, it may encase the carotid, and you may not be able to palpate.
Yes.
Okay.
You say
Okay, Dr. Kiruba,
sternocleidomastoid.
what is thyroid paradox? You said firm inconsistent. What is thyroid paradox?
Sir, in thyroid, cystic swellings also will appear firm inconsistency, sir.
Cystic swelling will also appear.
Will appear.
And what are solid swellings? Solid swellings also be firm.
Solid
Is
swellings
the
will-
paradox is that the solid swellings feel soft, while the cystic swellings feel firm. Right? This is the paradox. Okay, go on. Next slide, please.
Examination of neck, no palpable cervical lymph nodes.
Which cervical lymph nodes did you palpate?
So I palpated for first 2, 3, 4, 7, sir.
Could you come again, please? 7 and 1.
2, 3, 4, sir.
Level 1.
Level 1, 2, 3, 4, and 7, sir.
Okay.
What's level 7 lymph nodes? Which
Posterior.
region is?
Sorry, sir.
Huh?
1, 2, 3, 4, and 5, sir.
Which level is the central compartment?
5, sir.
No.
5 is the posterior triangle.
And what level is assigned to central compartment?
Central compartment is level 6, sir.
Good. And where is level 7?
So 7 is mediastinal node, sir. Upper mediastinal.
Obviously, you can't palpate them. All right. And you said you would palpate, will try to palpate right from level 1 to level 6. Fine.
5, sir.
Agreed, because you would do a complete examination of the neck. But which levels do you expect to be involved more in a thyroid carcinoma?
So first, it involves pretracheal and level 6 nodes, sir. Then it goes to level 2, 3, 4, and 5 can be there, sir. Level 1, it's rare in thyroid malignancy, sir.
Are you aware that level 2 is subdivided into 2A and 2B?
Yes, sir.
Which of the two is more commonly involved in thyroid carcinoma, 2A or 2B?
2B, sir.
Which structure divides level 2 into A and B? It's a spinal accessory nerve.
Spinal.
Can you describe the boundaries of the central compartment or level 6 lymph nodes?
Central compartment, upper border is hyoid bone. Laterally, both carotid, sir. Below suprasternal nodes.
Upper borders is the hyoid or thyroid?
The thyroid cartilage.
Thyroid cartilage.
And the lower border, you said, is suprasternal notch. Are you sure about that? Okay. There's a bit of, that's a bit of contentious issue. So majority of thyroid surgeons believe it is the innominate vein, the brachycephalic vein. Okay. All right. So go ahead with the presentation. No palpable cervical nodes, and what else?
Auscultation, no bluey heart. No eyes.
Where did you try to hear a bruit?
Superior pole of thyroid gland, sir.
Okay. But if you are bothered about,
tell me what exactly you palpated on palpation, what exactly you palpated parts of the thyroid? What did you palpate? You said inspector finding confirmed, correct?
Sir, I palpated on entire gland, sir. In that right lobe was found to be enlarged of
Right
about
lobe, what about left lobe?
the left lobe. Clinically, no palpable nodule, sir.
So did you mention that point? Is it important?
Yes, sir.
Suppose you have only one lobe, whole lobe is enlarged, isthmus is not enlarged, left lobe is not enlarged. Does it make some clinical diagnosis different? With
Yes,
only
sir.
one portion is
Yes, sir. It
it's
is
better.
solitary.
So I know, yes, I know usually a habit of telling that inspective finding confirmed. I'm not denying that, but make a special attention to palpate both lobes properly. If you are not palpated left lobe, to make it more prominent, what any clinical method you follow?
Piscilos method, we can make.
No. Pigilose for short neck. I said specifically if left lobe is not palpable, you have a right lobe is palpable. So you may have to do that method.
Yes, sir.
So please make a mention what is palpable. Right lobe is palpable, left lobe is palpable. Does isthmus palpable in your case?
Isthmus is normal, so isthmus is not enlarged.
Not palpable. If you see the picture, it is so grossly in. How do you know isthmus will be enlarged? Yeah, look at that. We can make out the tracheal deviation very significantly.
Yes, sir. Trachea is deviated.
What is this relationship of isthmus to the thyroid?
It lies in 2 to 4 tracheal rings.
So, did you feel the tracheal rings properly in this patient?
No, sir. It's shifted, sir.
So no, shifting is different. If you cannot feel, again, it means isthmus is enlarged. So by your description, it looks like right lobe is enlarged, isthmus is enlarged. According to you, left lobe is not enlarged. After giving a mention, you need to mention specifically the whole lobe is enlarged or what is enlarged. Any nodules are felt separately or not. That makes a difference. Did you feel the nodules?
No, sir. Surface is smooth, sir.
No. That is so you never felt any.
No, sir.
Because we
is the normal thyroid palpable, Dr. Kiruba? Is the normal thyroid palpable?
In thin patients, it's palpable, sir.
No, it is not. Right? So if you can palpate the thyroid, that means it is enlarged.
Okay.
You can, right.
Point is, if you have a no nodule, the whole lobe is enlarged, probably it goes towards adenoma. You heard of adenoma? So that's the time you can probably give such histological diagnosis. If you find nodules, obviously it goes easily for a classical, more common problem, multinodular goiter like that. So you have to make a careful attempt here. Is the whole lobe is enlarged? Only part is enlarged.
Yes,
Is it a smooth surface or nodular? Again, both lobes are enlarged or unilobar, bilobar, and again symmetrical or asymmetrical, and then isthmus is enlarged or not. So that's the important few findings. Rather than we get one just mention that inspective finding confirmed. That's all. Some correction. That's my say.
Have you palpated the pyramidal lobe? In certain specific condition, pyramidal lobe will be also enlarged, especially more of when you're thinking of Hashimoto's. There's a possibility of involvement of more pyramidal lobe also. So all the lobes, all the particular parts you should examine.
Okay, next slide.
Systemic examination, CVS S1, S2 hurt, RS normal vesicular vessels, per abdomen was soft, non-tender. Examination of spine and cranium was normal. Summary. A 53-year-old gentleman who presented with a swelling in the anterior aspect of neck towards the right, essentially small in size, now had gradually progressed to attain the present size of 6 × 5 centimeters. There's no history suggestive of hypo or hyperthyroidism. On examination, a swelling of size 6 × 5 centimeters is seen in the right lobe of thyroid gland. The lower border is seen and the trachea is shifted to the left and right carotid pulsation is pushed laterally. Left lobe is normal.
Dr. Kiruba, I would have liked if you had if you had examined the reflexes, if you have said that there's no pretreatable myxedema, and if you had examined for proximal muscle weakness.
Sir, as there's no history suggesting weakness, I don't take.
Examination,
No.
history is fine, but the examination should have to, okay?
Okay, sir.
Okay, what's the diagnosis now?
So solitary thyroid nodule in the right lobe of thyroid. The patient is in euthyroid state.
Okay, why do you think it's solitary? You think it's solitary?
Yes, sir. The right lobe of thyroid is enlarged.
Right, you should just say,
It's,
it is very difficult to appreciate just a solitary thyroid nodule, okay? Because they're usually accompanied by smaller nodules also. Okay, fine. Any differential diagnosis? Any differential diagnosis?
differential diagnosis, it could be a follicular adenoma or follicular carcinoma or papillary, or it could be.
You think it is benign or malignant?
Look, in thyroid, you must tell whether, with which you said, euthyroid or hypo. You must say whether it's a solid, it is a solitary nodule or multinodular got it. Sorry. And you must say whether it's benign or malignant.
What percentage of solitary solid nodule in male will be malignant?
48% chance of malignancy is there, sir. So I put in terms of malignancy.
That's a very, very large or high number that you've put it. Now, is it based, I mean, what kind of statistics is that based on? This notion that 40% of males with solitary thyroid nodule would be harboring.
By rule of 12, it's given in the men and female solid cystic. In male, solitary nodule with there's chance of 48% malignancy.
Yeah, that's the probability in surgical series. Patients who have undergone surgery, that is the kind of picture that you can see. If you go as per epidemiological data, in 50 years age, what approximately what proportion of all men would you expect to be having thyroid nodules? We did discuss about endemicity some time back. In an endemic iodine deficient area, what proportion of people you would expect to be having thyroid nodules? In iodine sufficient areas, what proportion would be having? Or can you provide a ballpark figure on what proportion of all adult males would be having thyroid nodules? And then what proportion of women?
So in the endemic area, both males and females is equal chance of thyroid nodules. In iodine sufficient areas, females will have more.
Okay. So that 48% is the incidence of nodules as such, or 40% to 50%, and not the probability of thyroid cancers per se, because that's a very, very large, very huge number. Okay, so I think it is worth re-emphasizing diagnosis in case of a nodular goiter or nodular thyroid swelling has 4 components. You have included only 2 of those. That's a solitary thyroid nodule and that it is euthyroid.
Sir, I think in terms of malignancy, sir.
You think this is malignant?
Yes, sir.
All right. So the third component is whether it is benign or malignant, and you think it is malignant, and I'll have to ask you what are your reasons for considering this as malignant, and what is the fourth component of a diagnosis of a nodular thyroid swelling?
Solitary or multinodular goiter, euthyroid or hyper or hypothyroid, benign or malignant, sir.
That makes it 3. What another feature you are bothered about, whether it is cervical or it is having retrosternal extension or is it thoracic? Okay, so maybe in usual cases, or perhaps including this one, you may not comment on it, but you must always keep this fact in mind, whether there is a retrosternal extension or not. After all, we want to have all such things, all such crucial things as part of diagnosis, which will have bearing on the management of a patient. Okay.
Okay, sir.
Now, please explain what makes you believe that this is a malignant nodule.
So first, it's a male patient, sir. And patient having a huge swelling, which is solitary nodule, and it's causing tracheal shift with carotid artery displacement.
Okay. Which of these features, male gender, 6 centimeter size, tracheal deviation, carotid arterial displacement, which of these are specific signs of malignancy, if any, or specific features of malignancy? None of them. What is the commoner pathology in this age group of, this age group men with a solitary nodule? What is the commoner pathology? Is it malignancy or benign?
So malignant.
Malignant?
Benign.
Yeah. Please do not misunderstand. Male gender has higher predisposition for malignancy as compared to females. But that doesn't mean that every man who has a thyroid nodule would have a malignancy. Okay? So when you're comparing males and females, the probability of finding malignancy is slightly higher in men as compared to women. That's all. But none of the specific features, clinical features of malignancy are present in this patient. Okay? So while it is correct or very appropriate not to rule out malignancy without appropriate evaluation, but at the same time, it is not correct to presume malignancy when there are no features. All right?
Okay.
I feel if I were to provide a diagnosis in this patient, I would say this patient has a euthyroid, solitary thyroid nodule, most likely benign, which is cervical. Okay. Now, what are you going to do for this patient?
So extension first, I like to do ultrasound, sir.
Okay.
Ultrasound neck to look for the size of the nodule and whether there is presence of other nodules in the opposite lobe, and to look for the echogenicity of the nodule, to look for the carotid, and to look for other palpable lymph nodes and vascularity of the gland.
Okay. What type of ultrasound do you use for evaluating a thyroid nodule?
So we use high frequency ultrasound of 10.
So you say high resolution ultrasound of the neck and not just of thyroid. All right.
Yes.
And you said a few things, a few purposes you did specify. In a patient who has a clinically palpable or visible nodule, the first purpose of ultrasound is what?
Is to look the echogenicity, nodule echogenicity.
Okay, so in other words, you're saying that you would like to characterize this nodule with ultrasonography, with the aim of identifying features
Of
which
benign
may
or
be-
malignant.
Excellent answer. So are you aware of any system using which ultrasonologist would categorize thyroid nodules?
So TIRADS they use.
Excellent. And
Includes-
what do you have the ultrasound? I mean, are you aware of the ultrasound findings of this patient? Perhaps not. So if I give you, this was a TIRADS 2 lesion, what does that signify?
TIRADS too, it's benign, sir.
Okay. Are you aware of what are the features on ultrasonography which suggest malignancy in a thyroid nodule?
So the nodule, if it's hypoechoic, and the absence of peripheral halo, cells are taller than wider with increased vascularity, associated with cervical nodes with loss of hilum.
Very good. So vascularity, specifically, where do you look for the vascularity?
Increased
Peripheral, or is it intralesional? There can be nodules which are highly vascular within the nodule, within the lesion, and then there can be nodules, almost all, which have a high perinodular vascularity. So it is the intralesional vascularity. Okay. Now, yes, you've done the ultrasound. What else would you like to do?
I like to do a thyroid function test.
In what way? What would you do to assess the thyroid functions?
T3, T4, TSH, sir.
All of them? All three of them? No.
TSH alone we can do it.
This patient was, you said, clinically euthyroid.
Yes, sir.
So now think and answer. What would you do to assess the thyroid functional status?
You are allowed to do only one test.
TSH, sir.
Urinary TSH? Salivary TSH? TSH in which sample?
Sir,
TSH in which sample?
venous sample.
Venous. Is that so? What I am hinting at is, when you are answering in the exams, provide a perfect answer. The perfect answer is serum TSH. Okay, and that is sufficient in vast majority of clinically euthyroid patients to document that the patient is euthyroid indeed, biochemically as well. And you do not do all T3, T4, and TSH in every patient. Please, that's not required.
Okay.
All right, let's not go into too many details, but if at all you have to do something beyond TSH, the best next test is to do a free T4, free thyroxine, not standard T3, T4, TSH. Okay. Now you've done ultrasonography and you may have done serum TSH, and let me say that this TSH was within normal limits. What next would you do?
Sir, I'd like to do a videoscopy to look for vocal cord status.
Oh, how is that going to help you with the diagnosis? Have we arrived at a diagnosis as yet? A diagnosis which will help us treat this patient?
FNAC I'd like to do, sir.
Okay, you would like to do a FNAC from
Enlarged nodule.
From the thyroid nodule. And how would you do that? How would you do the FNAC?
Sorry.
You are going to do ultrasound guided or?
I can do ultrasound guided FNAC, sir. Gives more okay.
You can do that, or what would you prefer?
Ultrasound guided.
Why? How is it? Is it any better compared to palpation guided?
Yes, sir. We can find the location of nodule. If there is associated cystic component, we can take FNAC from solid part and
Yeah.
Dominant
So
nodule, which
great. So if you have a solid and a reasonably small thyroid nodule, which is well palpable, I mean, this is not something I cannot say this is highly scientifically, backed by great quality scientific evidence. But if you have very small nodules, you must do ultrasound guided FNA. But similarly, if you have large nodule, you should also ask for an ultrasound guided FNA because there would be heterogeneity. There would be heterogeneous characteristic of this nodule. A small, uniformly hypoechoic solid nodule, maybe just a palpation guided FNA is good enough. And if after the first FNAC, which is not ultrasound guided, if there is a discrepancy between your clinical expectation and the FNA diagnosis, or if the FNA is inadequate or inconclusive, then you may repeat with ultrasound guided FNA. All right, so you have done this. What is this all combinedly called?
action in thyroid.
Quadruple assessment. Excellent. So what are the four components of this?
Clinical examination, radiological investigation, FNAC, radiological pathological FNAC, then genetic testing.
Oh. No. Where did genetic testing come in here? Why did you leave out the serum TSH? So the quadruple assessment includes your clinical assessment, serum TSH, ultrasonography, high resolution ultrasonography, and FNAC. All right. So if supposing I tell you this is a benign thyroid nodule, the FNAC, or to make it a little more interesting, this was a Bethesda 3 nodule reported on FNAC. What does that mean?
Bethesda 3 is ATP of undetermined significance.
So, what would you like to do for this patient? Total thyroid. Why? Let me, to make it clear to you, your clinical findings were that he has a solitary right thyroid nodule. The left lobe was not palpable, nor normal. And on ultrasound too, there are no nodules, there are no lymph nodes. There's only a solitary right thyroid nodule. And the FNA is Bethesda 3, which you said is ATP of unknown significance. Or is it something else?
Can repeat definition.
Okay. With what intention?
Ultrasound guided.
Okay, you may do an ultrasound guided FNA and expect what? How different this FNAC or the FNAC, the cytology report would be in this scenario. What is the commoner pathology? What proportion of all follicular neoplasms of unknown significance, or so unknown, AUS? What is the proportion of such patients who finally have a malignant disease? There has to be a range, of course. Tell me a range.
Then you have Bethesda 3. What is the percentage of it can turn malignant?
3 to 4.
Sorry, say that again, please. Okay, don't worry. If you do not know an answer, say so that we can go ahead to the next question. That is an important tip for any examination. All right. Otherwise, if you get stuck at this, you lose the opportunity of being asked a next question, which you can answer. Okay. So the range is wide. It is between 15 and 35%. So if your cytologists are very good the proportion of malignancy in this scenario would be low, say around close to 15%. But there are a number of cytologists who are not as committal. They would like to play safe. And for them, the probability of malignancy is higher. Anyhow, so if the malignancy chances are certainly less than 50%, or say around 1/3, why do you want to do a total thyroidectomy when the opposite lobe is totally normal and the patient doesn't have a malignancy? So what is the correct surgical procedure in this scenario? What is that called?
In this case, recurrent redo surgery will be difficult, sir.
We'll come to the need for redo surgery in a minute. But for a unilateral, benign or suspicious thyroid nodule, what is the appropriate surgical procedure? And obviously, it is not total thyroidectomy because I am asking you this question so emphatically. It is quite obvious that it is not total thyroidectomy. So what is the other option?
Hemithyroidectomy.
Hemithyroidectomy. Excellent. So the correct answer is hemithyroidectomy. Now you say that in case this patient turns out to be having a malignancy, what type of malignancy is this more likely to be? What pathology?
Follicular or medullary, sir? Sporadic medullary.
No, I'm asking you what is the most likely one single pathology? Most likely pathology, if this turns out to be malignant. It is papillary. Papillary is by far the commonest pathology. All right. So it is papillary thyroid cancer. And if it is indeed a 6 centimeter papillary thyroid cancer, the patient should have a total thyroidectomy. And then you'll have to do a completion thyroidectomy. And you say it will be difficult. Well, yes, completion thyroidectomies are somewhat more difficult as compared to primary thyroidectomies. But here, in this case, if you have done a complete hemithyroidectomy on the right side, and you have to now do a completion thyroidectomy, not expected to fiddle with the right side neck at all during the completion. All you need to do is do a completion on the left side. Using a lateral approach, you can safely do it. And in expert hands, though the chances of nerve injury and hypoparathyroidism seems somewhat only slightly higher while doing completion thyroidectomy as compared to while doing primary total thyroidectomy, but it's still not so greatly difficult. But the counter side or the other option that you said that you would do a total thyroidectomy right away, I don't think that can be acceptable. Why would you do total thyroidectomy to about 65% of all patients when it is not required, when they can be safely managed just with hemithyroidectomy? So you do not overtreat 2/3 of all patients because 1/3 of patients may require a completion thyroidectomy. All right. So you did say something about genetic testing. In which scenario would you ask for a genetic testing and which genetic mutations you are bothered about?
If there is family history of malignancy, then
Yes.
we have.
Oh,
Yeah.
okay. Don't get confused with. All right. Let me say you want to do genetic testing only when you're suspecting medullary carcinoma. That is when you do some sort of a germline mutation testing for RET mutation. Okay. You may also find somatic mutations, but that's something entirely different, even with sporadic medullary. But what else you need to know and answer is that in cytology aspirates, in the fine needle aspirates, you can do certain genetic tests. What are those? Especially when, yeah,
wash space and we can
sorry, I couldn't understand.
Say it
What?
again clearly.
thyroid peroxidase washout can be done in FNAC, sir. And,
How does that help? Are you aware of any gene classifiers? You were telling something about BRAF.
yes, sir.
Which BRAF and how does that help? So essentially, there's a whole bunch of thyroid aspirates where, or patients with thyroid nodules, where the FNAC is inconclusive. It is suspicious for malignancy, but not diagnostic. All right, Bethesda 3 and Bethesda 4. Or in which case you may like to confirm it further. All follicular neoplasms, the patient may not accept a surgery straight away. There you can do BRAF V 500, okay, and then aspirates. And you can also do some other, and then the multi-gene arrays. Let's drop it there. Now, if supposing this patient had a papillary thyroid cancer or a follicular variant of papillary, and you did a completion thyroidectomy, you've done a total thyroidectomy, and there were no lymph nodes, what is the next step in managing this patient?
The papillary carcinoma, if we have doubt, we'll do after 3 weeks. When
The way you do the categorization of that.
yes, sir. We'll categorize into low risk, intermediate risk, and high risk group. If the tumor is less than 1 centimeter and it comes under low risk, then we can put the patient on suppressive dose of thyroxine. If it's high risk, I want to go for radioactive iodine scan, so I'll stop the drug and make the TSH rise for more than 30. We'll go for radioactive iodine scan to look for any location of tumor. If it is present, we can go for radioactive ablation.
Very good. And how much dose of radioactive iodine usually you would require in such scenario?
For radioactive scan, we use 1 to 3 millicurie. For ablation, it goes around 100 to 200 millicuries. 100 millicuries.
Oh, no, don't say that. See, again, it depends on
The
what
site
is, yeah. So what do you do? How do you decide on the dose?
30 for skeletal, it will be higher, sir. Otherwise, 30.
Yeah, so if there is only thyroid bed remnant, you give 30 millicurie.
30 millicurie.
If you have some cervical lymph nodes too, the dose would be something between 30 and 50 close to 50 millicuries. And then if you have skeletal metastasis, you can go right up to 100, skeletal, pulmonary, elsewhere. Good. And then you said you would put the patient on suppressive dose of thyroxine. Excellent answer. What is your target TSH? How would you know that you have done sufficient suppression of TSH?
It also depends on the group, sir. If it's high risk group, I'll keep a TSH less than 0.1, sir. For low risk, we can keep less than 0.5, sir.
Oh, so for both, you would keep it less than 0.5.
High risk,
You
how
mean
much?
to say?
Less than
You mean
0.1,
to-
sir.
Okay. So you would suppress to subnormal limits if it is a high risk cancer. If it is a low risk cancer, you would suppress it to close to lower limit of normal. Okay, very good. How frequently do you follow these patients?
Sir, I'll follow with thyroglobulin and ultrasonic every 6 months.
And thyroglobulin, is that a stimulated thyroglobulin or a basal one?
Basal ones.
Basal? No. Ideally, you do it stimulated. And how do you get, what are the options for doing stimulated thyroglobulin? You said if this patient had a thyroid cancer, you would stop the drug, which I suppose you mean thyroxine.
Yes, sir.
So one is thyroxine withdrawal. Obviously, there has to be another option. What am I asking? What is the other option?
Recombinant,
Great. Go ahead.
recombinant TSH.
Recombinant TSH. Excellent answer. I think we have a nudge from Dr. Kanagvel that we have to stop here. But Dr. Kiruba, you've done well in most of the part. But as pointed out by other experts, clinically, you need to do somewhat better. Okay? In the clinical examination, history taking clinical examination, you have to do better.
Dr. Kiruba, do you have any questions or any doubts to be clarified? Now it is your turn to clarify your doubts from the senior faculty here.
It was given in Bailey, sir, about that rule of 12, and it indicates the chance of malignancy, sir. In that, it's given 48 solid cystic lesion. It's given 48% for male solid lesion, sir.
Okay, so possibly it is so, and as I said, that is from the surgical series of all such patients who undergo surgery and who have a solid nodule in male gender. Maybe that is the kind of figure you can get. But what I was discussing was that the true incidence is not based on surgical series. The true incidence is based on epidemiological studies. And in epidemiological studies, or even you can have within epidemiological studies, you have three options: clinical, autopsy, and ultrasonography or imaging. And all the three have a different figure. But 50% is, close to 50% is the incidence of thyroid nodules and not of thyroid cancer. So if only 50% people have thyroid nodules, not all of them are malignant. That is what I was hinting at. Okay.
Any other questions, Dr. Kiruba? Sana, share your comments, sir. Shanai, sir?
Yeah, I just want to tell you that if you palpate only a small portion of the gland with a nodule like, then only you offer solitary nodule clinically, and rest of the gland is not palpable. This is how it is. In your case, as I see, we don't have a advantage of palpating the case. We can only see. My one look is that the whole right lobe and isthmus seems to be enlarged in this. That's what it's looking like. That's why it's very important to realize that you have a one solitary nodule, do a Lahes method clinically and say opposite lobe, other side, is enlarged. Then it doesn't become solitary nodule in the clinical diagnosis. You may feel single nodule, but other lobe is enlarged. So your obviously diagnosis tilts to partly multinodular goiter. You understand? Other way, you may still have one nodule. It may still turn out to be multinodular goiter as far as the later on ultrasound examination. So then comes the DD for solitary nodule, they may ask. Is soft thyroid paradox has been asked to you. So sometimes the tense cyst can feel sometimes firm, even hard, especially in the thyroid. So you start with the diagnosis of solitary nodule, common maybe simple nodule of a multinodular goiter, yes. Autonomous toxic nodule, that's important if the pulse rate is high. Then comes adenoma. Then come those thyroid cysts. Yes, definitely well differentiated, all this carcinoma will come. These are 4 or 5 differential diagnoses to be kept in mind. And examiners will take you, depends upon their thing. Some will take you to papillary, some will take you to, they will tell you, say, same quadruple assessment, and then you say ultrasound FNAC, then they will tell this is follicular, only cells are identified. What will you do? Don't say that follicular carcinoma can be diagnosed. Okay, they may tell Hurther cell adenoma, which is obviously more aggressive. So Hurther cell. So they will tell even next step papillary carcinoma. How do you manage? This is how ultimately you'll be carried on to check all the 5 probabilities, whether you know or not, including MH. So it's a very interesting topic, and there are many more things are there in the solitary nodule. I think you should know about. Is a favorite topic. Yes, these are some comments. She has done well as per the presentation, and these things are concerned.
So you are mute. Kanaivel sir, please unmute.
Thank you, Shanai sir. Rahul sir, are you with us, sir? I think he's not with us. Any other faculty would like to give any comments before we close the session? Karnakaran sir. Naeem, do you have any questions, Naeem?
No, sir.
So thank you, Gaurav sir. Thank you, Rahul sir. And thank you, Modi sir. Modi sir, are you with us? No. Okay. So thank you, Shanai sir. Thank you, Jayalal sir, Karnakaran sir. And thanks to both the young students, Dr. Kirba and Dr. Naeem. I think they made this evening worthwhile, learning a lot of different things in a totally different perspective. I'm sure parotids and thyroids we have discussed more than 5-6 times before, but every time we discuss, it takes into a different perspective, and the level of discussion standards also going up. Thank you, Gaurav sir. Maybe once in 2 or 3 months, we will take your precious time for teaching the students. I seek your permission to do that. I understand you treat breast cancers as well. I would have taken a breast case if I've known that before, but then this student was contributed by Professor Sridhar from Apollo Institute of Medical Sciences. So we look forward for more collaborative programs with you also, sir. Thank you for joining this evening and spending your precious time, sir. Thank you very much.
Thank you.
And I thank all the faculty, Jayalal sir and other senior professors. Thank you for spending your valuable time for PG clinics. We look forward for yet another PG clinics coming Friday. Good night, everyone. And